Welcome to today's session where we will cover the diagnosis and management of hypertension in adults, including those with type 2 diabetes. This discussion will walk you through the key points you need for daily clinical practice. When measuring blood pressure in clinic, make sure to use the correct cuff size. If clinic blood pressure is 140 over 90 or higher, repeat the measurement. If the second reading is very different from the first, take a third reading and record the lowest of the last two. Always check both arms at the time of diagnosis. If the difference is greater than 15 millimeters of mercury and persists, use the higher arm for future readings. If the pulse is irregular, remember automated machines may not be reliable, so manual auscultation is better. Hypertension should be diagnosed using ambulatory blood pressure monitoring as the gold standard. You need at least 14 readings taken during waking hours to get an accurate average. If a patient cannot tolerate ambulatory monitoring, home blood pressure readings are an alternative. Home monitoring should involve 2 readings twice a day over at least 4 days and preferably 7. Discard the first day's results and average the rest. Clinic readings are used for screening and for assessing response to treatment, but diagnosis depends on out-of-office monitoring. Always look for target organ damage. This means assessing for cardiovascular, renal, and ocular complications. Order an each urine albumin to creatinine ratio and dipstick for hematuria, and blood tests including renal function, HbA1c, cholesterol, and HDL. Fundoscopy should also be performed to look for hypertensive retinopathy if there is target organ damage, but ambulatory or home monitoring is normal. Consider other causes such as heart failure or chronic kidney disease. It is also important to check for postural blood pressure drops, especially in people over 80, those with type 2 diabetes, and anyone with postural dizziness or a history of falls. Measure blood pressure after lying or sitting, then again after standing for at least 1 minute. A systolic drop of 20 or more or a diastolic drop of 10 or more is significant. If present, review medications and underlying causes. For ongoing monitoring, standing pressures should be used as the reference point. Same-day referral is required if you suspect accelerated hypertension, where there is papilledema or retinal hemorrhage, or if you suspect pheochromocytoma. These patients may present with labile blood pressures, postural drops, headaches, palpitations, pallor, or excessive sweating. Same-day referral is also needed if there are life-threatening features such as acute confusion, chest pain, heart failure, or acute kidney injury. For routine referral, think of younger patients under 40 with hypertension, since 10-year cardiovascular risk scores underestimate lifetime risk in this group. Refer if secondary hypertension is suspected or if a patient remains uncontrolled despite 4 antihypertensive drugs. Moving to management, lifestyle measures are essential for everyone. These include smoking cessation, weight loss if overweight, with around 1 millimeter of mercury systolic reduction for every kilogram lost, regular physical activity, and a healthy diet. Now let's talk about thresholds for treatment. If the ambulatory or home average is 150 over 95 or higher, this is stage 2 hypertension and drug treatment should be offered regardless of age. If the average is between 135 over 85 and 149 over 94, this is stage 1 hypertension. In these cases, treatment depends on overall cardiovascular risk. For patients under 80, if the 10-year Q-risk score is 10% or higher, or if there is diabetes, renal disease, cardiovascular disease, or evidence of target organ damage, then drug therapy should be offered. If the Q-risk score is less than 10% and the patient is under 60, drug therapy can still be considered since lifetime risk is underestimated in younger people. For patients over 80, treatment is considered if clinic pressure is above 150 over 90. Choice of first-line drug depends on age, ethnicity, and comorbidity. If the patient has type 2 diabetes, start with an ACE inhibitor or an angiotensin receptor blocker regardless of age or ethnicity, since these improve outcomes in all groups. If the patient is African or African Caribbean without diabetes, the first-line option is a calcium channel blocker, as this produces better cardiovascular outcomes than ACE inhibitors alone. For patients under 55 without diabetes, start with an ACE inhibitor or angiotensin receptor blocker. For those aged 55 and above, start with a calcium channel blocker. If blood pressure is not controlled with the first drug, move to second-line therapy by combining any two of the following: an ACE inhibitor or ARB, a calcium channel blocker, or a thiazide-like diuretic such as indapamide. For third-line therapy, use all three together. If blood pressure is still uncontrolled on three drugs, check adherence, confirm with ambulatory or home monitoring, and rule out white coat hypertension. If still uncontrolled, this is resistant hypertension. Fourth line options include adding spironolactone if potassium is 4.5 or below, with close monitoring of renal function, or considering an alpha blocker or beta blocker if potassium is higher. At this stage, referral is advised. Blood pressure targets should be tailored to age and frailty. For patients under 80, the clinic target is below 140 over 90 and the ambulatory or home target is below 135 over 85. For those over 80, the clinic target is below 150 over 90 with an ambulatory or home target of below 145 over 85. In chronic kidney disease, the target depends on albuminuria. If the albumin to creatinine ratio is below 70, the clinic target is less than 140 over 90. If it is 70 or above, aim for less than 130 over 80, unless the patient is over 80 years of age, where the target remains less than 150 over 90. White coat and masked hypertension are important considerations. White coat is when clinic readings are higher than ambulatory or home readings by more than 20 systolic or 10 diastolic at diagnosis. Masked hypertension is the opposite, when out-of-office readings are higher than clinic values. These patterns matter as they can influence treatment decisions and risk assessment. To summarize, diagnosing hypertension requires accurate measurement, confirmation with ambulatory or home monitoring, and an assessment of cardiovascular risk and organ damage. Management begins with lifestyle for everyone, then drug treatment depending on risk, age, and comorbidity. Stepwise drug escalation should follow the NICE algorithm, with referral if resistant hypertension is suspected. Finally, targets should be individualized with attention to frailty, diabetes, and chronic kidney disease. That concludes this session. Thank you for listening, and I hope this helps you approach hypertension in a structured and practical way for your patients.